you're coming to find out that everything is not textbook. So the importance of being a technologist is there's a lot more critical thinking than you thought would be coming into the program. Okay, a lot of critical thinking. So mobile and trauma radiography. Generally, the patient comes in on a wheelchair. They may be coming in on a gurney, a bed. They're going to be in a lot of pain. They may be sedated. They may be unconscious. And so because of their condition, they're not going to be able to follow your commands and instructions. So again, a lot of thinking. You have to be a lot of ingenuity, a lot of problem solving that's involved. Same thing with surgical radiography. When you're in an OR department, you have to anticipate the surgeon's moves. Be ready. Don't wait for them to tell you what to do. You should be at least 2 or 3 steps ahead of them. And that's what's going to make you a good OR radiographer, is being 2 to 3 steps ahead of the doctor. And that is a good way to build a good relationship and good rapport. So again, possible condition. Patients on their back, they're on a backboard, they may have a collar, they may have a splint, they may be wrapped up in tape, Velcro, different types of immobilization devices, and that's where your challenges are also going to lie. Now hopefully when the patient presents in your department, you won't see anything too nasty. They should be cleaned up, or they should be covered in some way. Okay? Rarely in my career as a technologist did I see anything sticking out, protruding, wide open. Am I serious?
I think my computer just.
Oh, okay.
Sorry.
Yeah, I'm serious. Okay. All right. Again, being skillful and resourceful is going to be the key in trauma radiography. Okay. So I've listed a whole bunch of different things that you'll be utilizing. Horizontal beams is you're not going to be straight up and down. There's going to be a lot of tubangulation. So instead of the patient moving laterally for you or in oblique position, now it will be your X-ray tube that goes laterally or in an oblique position. Okay, so that's where the challenges lie. We have some alternate imaging modalities that are required. If there's certain things that we can't do in X-ray, again, due to the patient's condition, there are alternate modalities that are available out there. So just look through them. CT, ultrasound, special procedures, the cardiac cath lab, nuclear medicine. These type of modalities are usually used for trauma type of situations. MRI, not so much, because the acquisition of these images are a little bit slower, and procedures that you do in MRI aren't considered emergent for the most part. Okay. Again, we have other modalities that will address that urgency to get the procedures done a little bit more quicker. Okay. Angiography. So how did you guys like the field trip?
It was
Pretty
awesome.
awesome, right? I saw how shy you guys were when trying to play with that X-ray, the C-arm in the cath lab. Now, if you are ever interested in doing something like that, what they were just showing you was a single plane C-arm. There's also such a thing as a double plane C-arm. Okay, so if you guys had fun operating one, try operating 2 at the same time without knocking the patient in the head. It's pretty fun. Okay. Okay, so here we have, this is done in the cardiac cath lab, or it can be done in special procedures. Pulmonary embolism. And it's hard to see, this image, but it is a nuclear medicine study. This is nuclear medicine. Also nuclear medicine. I cringe every time I see this.
What?
Yeah, testicular torsion. Looks like a punching bag. Skeletal trauma and fracture terminology. Okay, so here we go. Again, this is going to be a review for, in the most part, because we've covered a majority of this terminology back when we covered the different parts. Okay, so this is going to be review. So the term dislocation also is luxation. So those terms are used interchangeably. So dislocation and luxation is the displacement of a bone from the joint. Questions? Okay, let's keep on going. Dislocation again is luxation, bone displaced from the joint. Most common places for dislocation is the shoulder, the hip, the thumb especially, and the patella. Those are the most common places. For the elderly, it's generally the shoulders and the hip. We see a lot of those coming through the emergency room. A lot of those. Okay? So what the doctor will do is they will take a picture of either the shoulder or the hip. Then what they will do is they will pop the joint back into place. It's called a closed reduction. Okay, we'll talk about closed reduction later on. But popping it back into place, closed reduction, and then we'll do post images to make sure that it is popped back into the socket. Okay. Dislocated patella. Do you think they've torn some ligaments on this too?
Yes.
Yeah. Yeah. So they can pop it back into place, but it's a long road to recovery. Okay, subluxation is a partial dislocation. Sublux is a partial dislocation. We have a good example of that right here. We have 1, 2, 3, 4, 5. So this is a sublux of C5. Are you guys okay with this x-ray? Are we seeing all the way down to 7? 1, 2, 3, 4, 5, 6. Not really, right? So again, good lateral C-spine is to see C7 and T1. A sprain is a forced wrenching or twisting of a joint, resulting in a partial rupture or tearing of the ligaments. A fracture is a break in the bone, and a contusion is a bruise type of injury without a fracture or break in the skin. So again, a contusion is a bruise type of injury. Can you see bruises on an x-ray? Can't see bruises in an x-ray, can you? No. Okay? But the doctor would want to see whether or not, if it's badly bruised, if it's a real bad contusion, they also want to see if maybe there may be some injury to the bone or the joint. But you can't see a contusion on the x-ray. You can see it physically as it's, bleeding out, the blood seeping underneath the tissue, right? That's what a bruise is. Okay? So here we have an x-ray of a contusion. We're going to take an x-ray, okay? But here they found out that there might be a possible avulsion fracture. And avulsion is a separation of the bone. It's considered a fracture. It's a separation of the bone due to the pulling of the ligament. Okay, so here, part of the pelvic bone got pulled from the ligament, with the ligament. Nursemaid's elbow, also called jerk elbow, where there is a radial head sublux. Sublux, is that dislocation or partial dislocation? Partial dislocation, okay. So caused by the sudden pull or on the extended pronated forearm, such as by an adult tugging on an uncooperative child or by swinging the child by the arms during play. Okay. So here, it's a child. It's kind of hard to tell if there is a sublux. And remember way back when we were doing extremities, was that this semester or the semester before? Semester before, okay. Remember we were looking at soft tissue and fat pads and things of that nature? Can you see this line going across? Okay, that's not the crease on the elbow. That is an interruption, okay, of one of those fat pads. Okay. Now, what about this? Is this considered a fracture?
Plates? Plates.
Yeah. No plates.
Yes, plates.
Yes. No,
Plates.
it's not a fracture. It's
No, meaning yes, plates,
yes,
no
plates,
fracture.
no fracture. Okay, terminology of fracture alignment, apposition. If there is a break, the break can be opposed, meaning that they are still properly aligned. So you can have a break that is opposed. Okay, they're opposed, so they are properly aligned. If they are not properly aligned, it's called lack of apposition or distraction. So again, the ends of the fragments do not make contact. Here we have an example of one of those distractions. It's called a bayonet apposition, where the fragments, the end of the fragments overlap. Okay. Here's an example of a bayonet apposition of the clavicle. What can they do about that? Well, they can't do anything about it. Most of the time, the doctor will say it'll heal on its own. So there's going to be an overlap, and eventually what will happen is these bones, this area of the bone here, will fuse together. Okay, they're not going to go and fix that. They'll just put you on a splint for about a month or two, take some follow-up x-rays, and look to see if it's fusing on its own. But they won't do anything
What
to
if
that.
there's shards in there? What if it's like,
Doesn't matter.
it doesn't matter?
Yeah, the question was if there's shards, little pieces, it doesn't matter.
Oh, shards.
Yeah.
Shards of bone.
Did you say shard?
Shards of bone.
Oh,
You
shards.
get to- Not metal or anything.
That's what all the way there.
Okay. Right. Still talking about fracture alignments. These terms will describe which way the apposition is going if they're not properly aligned. So the first one here is a varus angulation. And this is where the ends of the fragments are going away from the midline. And that you've got the ends of the fragments here going towards the midline of the body, and that's called valgus. So varus towards the lateral side, valgus going medially.
I'm confused.
Okay?
In general.
The ends of the fragments, so it's not properly straight. You can see that, right? It's pointing away from the midline. It's the midline of the body. So the break is pointing outward, laterally.
Okay.
Okay? So that's varus.
Okay.
At the break, the ends of the break are pointing inward towards the midline of the body, and then that's valgus. I got a couple of extras here that'll show that. So this is a break pointing away from the midline, so this would be called what? Is this varus or valgus? This is varus, right? It's pointing away. That's varus. And then this is not a break, but it is a type of condition. So this is pointing inward. This is hammer toe. You guys have ever heard of hammer toe? This is hammer toe, okay? So this is just to give you an example of the joint pointing midline, okay? So this would be I forgot what it was called, a valgus deformity. Okay, types of breaks. A simple fracture is where the bone breaks but does not break the skin. It doesn't protrude through the skin. Compound fracture is where the ends of the bones, the fragments of the bones, do protrude outside of the skin. Also known as an open fracture. Then we have an incomplete fracture, where it does not traverse through the entire bone. Okay, so here's an example of an incomplete fracture. Most common in what age?
Child.
Kids, okay, because there's not a lot of calcification yet. Their bones are very pliable, so it'll break at one end but not on the other. Okay. Some examples of incomplete fractures also include porous and also plastic. Here's an example of a porous fracture, also known as a buccal fracture. It's buckling. So parts of the bones are kind of forced into each other without a complete break. It's still an incomplete break. Okay, so in this case, the incomplete fracture of the shaft of the long bone that is characterized by bulging of the outer cortex of the bone. Okay? Again, usually happens with younger kids. A complete fracture is a break through the entire bone. They can also be described in the break. Is it going across? Is it going longitudinally? Is it going down in an angle? Is it going around the long bone? So here we have transverse, where it goes completely across. Then we have an oblique. Then we have the spiral fracture. What are these kids doing? This is a kid too, right?
Having fun.
Yeah, having fun. Okay, so a complete fracture is when it breaks into two pieces. Again, we have transverse, oblique, and spiral. Then it can become a little bit more complex where it breaks up into several pieces. So that would be your comminuted fracture. You have the segmental fracture, which is a double type of fracture. I'll show you guys images. A butterfly fracture, and then a splintered fracture. Again, two or more fragments, comminuted. Here we have segmental. A bone break is in which several large bone fragments are separated from the main body of the fractured bone. So we have pre and post images. So when they try to fix a fracture like this, they'll be using a C-arm. Okay, the doctor will have you position your C-arm in an AP projection or in some kind of angle, because they remember as in X-ray we need several angles. We are three-dimensional, so we need to look at it from different perspectives. So you'll be assisting the doctor by providing fluoroscopic images while they're working on that patient. Here we have I don't think you guys have this on your image. I found another butterfly fracture. Okay, so I found that. So I just added on to our collection here. So two fragments on each side of the main in a wedge-shaped fragment. Okay. So this is the butterfly fracture or the butterfly effects. Not to be confused with the butterfly effects. Did you guys ever see this movie?
Yes.
It's mind-boggling. Yeah, it makes you think. Yeah, it's pretty cool. All right. Splintered fracture, bone splinters into more than two fragments. Then we have, out of fractures, okay. General types of fractures, impacted fracture, one fragment impacted fracture, one fragment driven into another ends of the bones. I think I showed you guys a really good one last semester with the shoulder, where the humerus was driven into the head. Okay.
Dr. F,
Yes.
what's the difference, like visually, between splintered fracture and comminuted fracture then?
This is considered a comminuted
Oh,
fracture.
it's-
Comminuted fracture is just a general term.
Okay.
Splintered is a specific terminology.
Thanks.
Yeah, so comminuted is general, splintered is specific. Okay, so here's it's not the same X-ray that I showed you guys before, but this is an impacted or buccal fracture of the shaft of the humerus being driven into the head of the humerus. But you'll see though that there is some buckling, but you'll also see there's another fracture over here that's causing separation of the head and the neck. You guys remember there's two next to the humerus. You have an anatomical neck, which is more proximal, and you have the surgical neck that's way down here, where the break is more common in the elderly. Okay. Okay. Fractures named after some important person who discovered it, I guess.
Or who inflicted it?
Barton's fracture, intra-articular fracture. So that means that the fracture is within the joint space. It's within the joint space. So intra-articular fracture with carpal displacement. Okay, so you can see that the carpal bones are separated from the radius and ulna. That's your Barton's. We have a Bennett's fracture, which is a fracture of the base of the first metacarpal. I think for this one, especially if it's a fracture of the first metacarpal, this is also known as the skier's thumb. You guys remember the skier's thumb? So that's an example of a Bennett's fracture. Is that skier's thumb? So skiers, poles, straps, they fall. Strap, grabs onto the thumb and pulls it back. Boxer's fracture, fracture of the distal fifth metacarpal. I showed you guys x-rays of that too, right?
Mm-hmm.
And you remember what this little nugget is right here? Is that a fracture?
Sesame bone.
Sesamoid bone. Okay.
Sesame
That's your sesamoid. It helps in the movement or articulation. Hangman's fracture. Fracture of both pedicles or pars inticularis of the axis vertebrae, also known as C2. Are you guys okay with the speed?
Mm-hmm.
That okay. That's perfect. Okay. Sometimes I feel like I'm talking too fast.
No. Nope.
Okay.
Speed it up, please.
Hutchinson's fracture, also known as the chauffeur's fracture, is an intra-articular fracture of the radial and styloid process. How does that happen? Steering wheel. Sudden impact. Holding onto the steering wheel. Okay, so your wrist is driven into your radius and ulna. Okay? So intra-articular, again, it's within the articulation. Intra-articular fracture of the radial styloid process. Some more named fractures. We have Montesia's fracture. It's a proximal ulna fracture along with dislocation of the radial head. Then we have the Potts fracture, which is an ankle fracture of the distal fibula with frequent fracture of the medial malleolus. So let's look at a Montesia. Fracture of the proximal ulna with dislocation of the radius. Then we have, what happened here? Why not have a Potts? I don't have a Potts. Okay. Colles fracture is a posterior displacement of the distal radius. Posterior displacement of the distal radius. So let's look at a Colles fracture. You guys remember this, right? Mm-hmm. We had this previously, okay? So Colles fracture, fracture of distal radius, displaced posteriorly. So it's displaced towards the back, anatomical position, right?
Okay.
It's displaced towards the back in an anatomical position. Oh, my granddaughter had one of these. She fell off the monkey bars. Yeah,
What's monkey bars?
the monkey. monkey bars, playground. It can be like the spider web, or it can be
Jungle
gym. Yeah, jungle gym. What's a jungle gym?
What's the jungle? What's gym? What's jungle? And what's the jungle?
And then this is the opposite. Now we have an anterior displacement. Anterior displacement. Okay, and what is this called? Smith's. Fracture of the distal radius displaced anteriorly, again anteriorly in an anatomical position, towards the front. Okay there? Blowout fracture. I just added this. This is a coronal CT. I also found a typo. It's yours says fracture to the orbital floor or lateral and lateral orbital margins. It should say medial for a blowout. Okay, it should say medial, not lateral. So on your slides, change it from lateral to medial. Medial is correct. Lateral is incorrect. Okay, and you will see here in this CT scan, you have a blowout fracture of the lower orbital floors, and then compare the two sinuses. Here is air. What's happening over here? Is there air on the left side? That's actually fluid leaking in, right? Now let's look at the x-ray. You guys see fluid levels on the left maxillary sinus?
Yeah.
See that? Yeah. Okie dokes. Questions? Compression fracture. Here's an example of a vertebral body collapse or is crushed. Okay, compression fracture. There is compression and ends up usually looking like a wedge shape. So compression fracture with a wedge shape is generally what happens in the lumbar region. We have a depressed fracture. This is an example of a ping pong fracture. A break in a cranial bone or crushed portion of the skull with depression of the bone in towards the brain. So we have diagnostic x-ray. Here we have a CAT scan. A chip fracture is an isolated bone fragment. Again, it's isolated, so don't get that confused with an avulsion fracture. An avulsion fracture may look like that, but an avulsion fracture is caused by the pulling of the ligament. Okay? Pulling of the ligament that causes the separation of the bone. This is just an isolated bone fracture. It's a chip fracture. Okay? Again, not to be confused with a chip fracture. Where's this character from?
Beauty and the Beast.
Is it Beauty and the Beast?
His name is Chip.
His name is Chip. His name is Chip.
So now Chip and Dale.
Only Disney fans will know.
Extra credit, please.
Okay, then we have the stellate fracture. Fracture lines radiate from a center point of injury. Tough fractures are comminuted fractures usually occurring at the distal phalanx, meaning that this can happen with your fingers and the toes, right? Tips of the phalanges. It's a tough fracture. Okay? Getting your finger caught in the car door. Some heavy object falling on your toes or on your fingers. Okay? These are pretty bad tufts and burst fractures. We have the slides? We have these slides? You guys have these, right? Okay, all right. Here's a stellate fracture. This is what it looks like. It's not radiographically. This is what it looks like. And this is what it looks like after surgery has been done. So this is an open reduction. They put screws, they put wiring in there. Sometimes they may leave the hardware in there, but oftentimes they'll go back to surgery and have the hardware removed after the bones have fused together. Okay. So again, sometimes they may leave it in there, sometimes they'll remove it.
Bless you.
Bless you. Okay. Stress fracture. It's another name for shin splints, right? Splintering of the bone caused by repeated stress. Okay. It's also called the fatigues or March fracture. My son, who was military, when he was in the Marines, he actually got one of those, and they wouldn't let him participate for about a month. And he was like, "I'll just get over this, not a big deal." But they said, "No, you need to have some time off because of that." That was nice of them, right? But I thought they were supposed to build, you know.
Yeah, runners run with those.
Yeah, runners do it all the time. Yeah, but they gave him medical leave for about a month. I'm like, why? You're a man. Deal with it. Trimalleolar fracture involves the medial lateral and the posterior malleolus. This is a picture that I showed you, that I just put up there, just to give you an idea, because you're only seeing the lateral medial. Here is a lateral view, so there's also a posterior malleolus. Okay, so that's trimalleolar. So there is a posterior malleolus that's coming out of the tibia. Okay, so it comes out of the tibia. So here we have the lateral, but in the back of it. I'm sorry, this is the medial. Tibial is lateral, right? Okay, so tibia is medial. So here's the medial, and on the back side it has the posterior. Epiphyseal fractures through the epiphyseal plate. They have different classifications due to the type of injury, due to the type of fracture. So there are classifications, and this classification that deals with epiphyseal fractures is known as the Salter-Harris fracture classification. Okay, I don't need you guys to know all the different types, but be familiar with Salter-Harris. So again, classification of plate fractures is called the Salter-Harris. Okay. Again, these type of fractures are common in children. Okay. So here we have an epiphyseal fracture, but what else do we have? See any other fractures there?
Fragment? No. Oh, wait, that one.
Green stick. Is that you, Max? Yeah, green stick. You also have a green stick fracture. All right. I think that's it for the fractures. I think your book has more, so look through your textbook. How are we going to address these different types of conditions when taking an x-ray? Remember, this is trauma radiography. So what they're referring to in this particular slide is how is it they're going to fix the fracture or the dislocation. One way is to manipulate the fracture or the dislocation without cutting up the patient. This is known as closed reduction. So they just manipulate it through the skin and the tissue and the muscle. Okay? Trying to put it back into apposition. Remember that term apposition? They're trying to line it up. So this is closed reduction. Open reduction is where they have to do it surgically. So now the patient has to go to surgery. They got to open it up, fix the fracture or fix the dislocation. But it does require some kind of opening of the tissue. Okay. C-arm is usually the modality of choice when doing these type of studies. Okay, for both open and closed reductions. And we need at least two views, two angles, to make sure that they are properly aligned. You guys remember the rules, right? At least two projections 90 degrees from each other, right? A minimum of at least two views. It also applies to trauma radiography. So here's an example of an ORIF, stands for open reduction with internal fixation. Internal fixation is referencing the hardware and trying to oppose the fragments. Okay, so there is hardware that is involved. Okay. How many of you guys have ever been in an ORIF in surgery? Have any of you been one? Okay. Okay, so a couple of you guys. Okay. How do you like the smell of cauterized tissue?
It's interesting.
It smells like a burned pig skin.
Someone says it's interesting. Someone says it smells
Yummy, delicious.
What's going on?
We've been on the table.
We've been on the table.
You've been on the table. What?
No, because we have had surgery.
What do you mean?
Yeah.
Oh, you've had it done.
Yeah, we've had it done.
Oh, you've had ORIFs done.
It's on top of the patient.
It almost
Yours
smells
is
like,
ankle, right?
yeah.
And what was yours?
Same ankle.
Same ankle.
Same ankle?
Yeah.
Would you guys do the same thing at the same time? What would you guys do?
Together, I don't know.
So, if you've ever smelled skin cauterizing, it smells like hamburger.
It's like a burn, a
With a
chicharron,
little bit of hair.
burn pig skin.
Yeah, it actually smells like someone's barbecuing.
Smells good.
It gets me hungry. So I avoid trying doing ORIFs when it's around lunchtime. I'm serious. When we had surgical procedures that were ORIF around lunchtime, I totally avoided it. Yeah. Smells like hamburger. Okay. Trauma adaptation positioning. Principle number 1. Again, patient can't move, right? So you have to be resourceful. You gotta have tube angulations. You have to use sponges. You have tape, different types of things. But again, the main thing here is, again, you need to acquire at least 2 positions or projections 90 degrees from each other. Now, the patient's not going to be able to position for you, so it's going to be your tube that's going to acquire those projections, right? So 2 projections 90 degrees from each other, often with no patient movement. Okay, you have to adapt. You have to think. Yes?
Yeah, please don't move. It hurts a lot when they